So I've done a bit of an intro already, but just to say that the content, my piece of this is going to draw on an internship I squeezed into my doctoral fellowship on at Duke Health, which is a big center in the US in North Carolina. And they have this team called the Duke Institute of Healthcare Innovation, which sits between the university and the provider institution over there. And that has got lots of experience in implementing AI, essentially. My PhD work more focused on a particular tool and the journey that has through implementation. So it's been helpful to see that kind of through both lenses of the process and a single product. So before we get going, I just wanted to first see if my slides are progressing, which they are. And then I'll move on to talk a little bit about what distinguishes AI. I'm very careful not to speak it as a kind of unique thing, because I don't think it is. And I think that kind of attitude of AI exceptionalism is unhelpful. But the very fact that we're having this call, I think, kind of points to the fact that it does have some kind of distinctions, even if they're just subjective. Talking a bit about what the implication of those distinctions are, and then we'll kind of get into the meat of things, which is me talking about this process of procurement and life cycle management for AI tools that I learned about through work with the US team. And then I'll hand over to Addy, who'll take a much deeper dive into a really useful tool for evaluation, but also monitoring of AI products. Also, please do stop and ask if it's helpful as we go along, but it sounds like there'll be lots of time for questions at the end, so we can dig into things then too. So this is not a hard and fast list, and like I say, these are distinctions, not unique characteristics, but they also tend to occur together, which I think has certain effects. And they're things that lots of people have said. This is not just me. So one thing I think that's important is that both between time and place, AI products, the performance can be expected to change, and it can be expected to change in unanticipated ways as well. AI, a lot of the value proposition and the hype that surrounds it is a kind of assumption that it will be able to be attributed more complex tasks as well. Now, obviously, that's not a necessity, but I think the reason it's given the treatment that it is because that's how we assume we're going to make use of it. The next characteristic I'd like to point to is the kind of low explainability or black box phenomenon, which is an important overlay over these other things because concerns that arise there are sometimes hard to unpick. And then the last one is kind of what I was pointing to at the beginning, which is regardless of your buy-in to these first 3 points of whether or not those things apply to other health tech, people think it's different, or a lot of people do. And so the way they react to it, the kind of bars that they measure it against are different. And the conflations they draw with sort of AI killbots or large language models or whatever's on the news at the time is problematic sometimes. And thinking about the consequences of those things, again, heading back up to the top, when we're planning monitoring, it's really important that it's very effective and accounts for changes that we don't anticipate. So our unknown unknowns, as well as the kind of known unknowns. The kind of complexity of the task that the AI takes on has quite a big implication for the professional threat that a doctor's experience, because, you know, people say doctors don't hang their hat on their ability to write well if a digital tool takes that over, whereas if it's a diagnostic decision that they've trained for years to be able to do, there's a little bit more discomfort there about the kind of role it might occupy. For the black box thing, there's a kind of tech solution to this, which is to try and squeeze as much explainability into the products as possible. But there is a hard cap there of how much you can gain. And I think a bigger part of the solution is perhaps thinking carefully about the use case that you assign to AI and assigning use cases and engineering them in a way that you can make peace with limitations to the explainability of what's going on. And then the final thing is that education is really important in AI because people have all sorts of diverse opinions, some of which are helpful to what you're doing, some of which are really important to listen to as well. And I know that's important in any kind of digital transformation consideration, but I think it can be even more important because of these other characteristics. So now I'll just push on a little bit to talk a little bit about this problem. Sorry that this is lifted from all sides, so the head is a little off there. But the point is to say my role in this was to lead the analysis of the data, by which I mean interviews. But it was a huge team, and which I was just a small part of. spread across lots of different kind of trailblazing centers in the US with legal expertise, operational expertise, clinical, technical expertise. So it's a fantastic opportunity. And the community is alive and continuing. It's called the Health AI Partnership, and you can look it up and even plug into it if that appeals. From our point of view, I think the problems that it relates to is the observation that now actually probably more than half of NHS trusts have adopted an AI-enabled software medical device, but there's little out there about people's experiences, what went well, how it should have gone. And I think it would be enormously valuable if we had that kind of peer-to-peer discussion, which is why meetings like this are fantastic. The second thing is that if we're going to make the assumption that AI is a good thing and carries clinical or operational benefit, then there's a risk that different trusts are going to be more capable of accepting it than others. And that's going to lead to further variation in those kind of quality or productivity metrics between trusts, which is something that would be great to mitigate by, again, kind of sharing knowledge between the community. And that was the point of this project. They're based in the US, essentially. So what they wanted to do was explore the perspectives that adopters across the country had with their experiences of independently developing and deploying AI products. And many of these centers have had AI workflows live for a couple of years. Duke, for instance, I think they had 14 tools in live workflows, most of them developed in-house. And then try and kind of pull together all these learnings and abstract them a little bit. So we've got some kind of process or toolkit that people can follow and build off or reinterpret in their own context. And just to give you a sense of the scale of this, there were 89 semi-structured interviews, and that's massive for a qualitative research study, each of them about an hour on average. And they came from lots of different places, but largely academic medical centers or systems. In the US, it's a bit different. There's more autonomy ascribed to these providers. There's some examples of what they call kind of federated systems like Kaiser Permanente, where they are separate hospitals, but they are almost like a franchise, if you like. So it is a kind of healthcare system, but not in the same way that we think of the NHS. And there were also interviews with kind of topic experts like ethicists or legal experts, things like that. And there was a bit of an inductive and a deductive process in pulling all this together, by which I mean we went from the data, from the interviews to some ideas, but then we also went from ideas to the data. So the first step was inductive, which was me and a colleague looking at interview data and basically trying to piece this apart into a process of how do providers go through AI implementation. We then kind of presented that to that big group of experts with various different expertise, and they kind of framed it pragmatically in a way that meant something to practitioners. Essentially, there's not too much of an academic navel-gazing exercise. And then we took that in a deductive way back to the remaining data as we went through the remaining 89. And that helped us to really characterize each of these points, but also test that they are valid and make sure we weren't finding information that went against that kind of deductive reasoning. And really, this 8-step process is what fell out the end, which is inevitably a bit reductionist, but the whole point of this is to produce something actionable. So I think the balance here is right. And I've put a link to a website here below, which is a fantastic web tool. There's an associated paper as well, but it's worth a look if you have the time, because each of these decision points, it breaks down into questions you could be asking yourself and case studies of how other providers dealt with those experiences. But I'll just run through it here quickly and then hand over to Addy. Much of this won't be new to you. I know this is very mindful, there's a lot of experience on this call, but some of it is slightly different perhaps for AI considerations, but I'd be interested to hear any kind of reflections on that. So I think first and foremost is that problem orientation is key. What you really don't want is somebody going, oh, I've got this cool AI tool, how can we use it? The question needs to be, I've got this problem, how do I solve it? And it's really important as well, even though this is the AI lifecycle, that step 1 is not AI specific, nor is step 2. You know, the solution doesn't need to be AI either. But once we've got that problem, you need to think about what the solution is. And this is something that our team has struggled with a few times, is that it's actually pretty hard to have oversight of what the regulated menu is to pick from. So interrogating regulatory databases is really hard to see what the tools are And what's even harder is to actually see what intended use statement they're regulated against, to actually get nailed down what is within scope of use and what is not, because there's a big risk that users can start to use tools for things that they're not really meant to be used for. And then that first step is badged as a kind of procurement phase, and the next thing is a kind of development phase. And to be clear, that doesn't mean development of the technology, that really means development of the healthcare pathway. And this is a really important step. I was on a call just this morning with a team from Exeter working through these things for an ophthalmology use case. But essentially, this pathway is place-based in its focus. What success is needs to be locally defined by key stakeholders and decision makers. So you need to kind of get it from the horse's mouth. What does good look like? And how do you measure good? And if I present you this measurement of good, will you be satisfied by that, or do you want to know other things? And you want to do that a priori. And then once you've got that, you can start thinking about what the workflow looks like. Now, with all these kind of things, as with, again, very mindful of the experience in the room, you may well have to change the workflow, but you want to minimize that and remove as much pain and shock from those changes as you can. So as much as you can kind of seamlessly place the AI in the workflow, the better. But inevitably, there'll probably be some changes to the way people work, and you need to figure that out in partnership, ideally, with the people on the ground. 5, I'll leave to a reasonable extent to Addy, because he's got a lot of great stuff to say about that. But that's a kind of reasonably rigorous evaluation before you hit go. I would say number 2, I would put in the kind of due diligence level of evaluation, where you're checking feasibility, making sure IG are happy, legal are happy, these kind of perspectives on a tool. But 5 is really doing a proper kind of service evaluation before launch. 6 is that launch bit, and very mindful that there's a lot of pain locked up in that small box with 4 words, and obviously that integration step and clinical rollout is very significant, and doing that in a staged way, with lots of kind of communication training, just like any other kind of digital transformation, is really important. Again, Addy's got some great insights into number 7, but 7 and 8 you can see in different color there is this kind of life cycle phase. So monitoring is really important, and it has kind of 2 aspects to it. There's one relatively continuous light touch, kind of canary in the mine, some kind of signal you have that drift is happening, something's going wrong. And that is kind of use case dependent, and what your success measures are and that kind of thing. But it's important that there's something, even if it's, you know, human in the loop and some kind of mechanism for people to raise their hand. But the other thing is a periodic deep dive, a kind of audit, if you will, which may be on an annual basis or 6 monthly or something like that, which needs to be agreed by the team. But that gives you a more rigorous sense of what's going on and really drills down into things. Then the last one is to make sure that people are thinking about the whole thing, all the way up to kind of decommissioning. And that very much needs to be on the list. And it's helpful to define a priori what kind of events would trigger us to say, hey, we've got to decommission this. That's the other thing to say about number 7. Audits can happen on a yearly basis, but you also need a list of events that are going to trigger another deep dive. So that might be a new PACS, a new X-ray machine, a new blood test analyzer. There are kind of events that would make you adequately suspicious that something's going to go wrong, that it's worth a deep dive rather than just that kind of casual monitoring approach. Yeah, so the point of this is really to kind of line it all up, improve your visibility of the whole process, and just as a kind of framework to interpret in your own context with your own stakeholders and priorities of what this would look like. Because like any of these things, it's a little bit overwhelming, the whole process without a kind of guide. So that's the idea here. And there's a lot more detail behind each of these boxes, as I say, which we can either talk about, or there's that link on the bottom, which I think will hopefully be valuable. So that's all I really wanted to squeeze into my bit. Oh, I've got, if it's helpful for conversational purposes, I've got a little more detail on each of those with a kind of illustrative quote from the data, just to prove I'm not making it up. But I don't think we need to dive into that right now. I think from this, it's important to remember that this is in the US, and there are some key differences there. One is the kind of autonomy of the individual providers. The economics of the situation is a bit different, but also the kind of technical capability of many of the trusts. Like there's a staff of data scientists capable of building these tools in-house, and that's how a lot of it happens. So that's an important thing to consider. I think having seen this community, this health AI partnership develop in the States, there's a lot of value to that community from those connections. And I think thinking about how we kind of nurture those conversations and networks is a really important take home from this. And another observation that it would be great to hear perspectives in the room about is how you can project these processes across different organizational structures. Just the job titles between trusts in the States differ enormously, never mind the actual roles that lie underneath those job titles, and understanding how to attribute the process across those kind of organizational structures is a really good question. And also getting the feel for this and how it's different from a dermatology tool, from an EMR deterioration index, for an X-ray analysis tool. You know, kind of figuring that out is also something that will be really important. So I'm going to hand over to Addy at this point. So I'm just going to stop sharing, and hopefully that works for you, Addy, and the microphone is behaving itself. But I'll pass it over to you.
Thank you, Jeff. I'm hoping that everyone can hear me. I was having some audio issues before. Amazing. I'm just gonna. I am just going to share my slide. Okay. Sorry, Jeff. Do you mind just carrying on with your slide share, because Teams is giving me some flagging up some issues. Brilliant, thank you. Great. So if you, if you just go hit next onto the next. Great. So thank you. So what I'm going to do is give you a very brief overview of the medical algorithmic audit, which is a framework that was developed and published in 2022. And I'm just going to talk a bit about how we're using it in UHB and a few of the use cases that we're using it with in terms of context. And then I'll just summarize some of our key learning at the end and just talk a little bit about kind of what the next steps are with this. If you just go next, Jeff. And if you just hit next again. So we know that the kind of the evaluation pathway is has been around for a while for things like pharmaceuticals, i.e. drugs, but also other medical devices. And we know that kind of this is kind of been around for a while. So we have preclinical trials, the different phases of clinical trials, and then a period of pharmacovigilance. And if you hit next, Jeff, we know that actually for AI, we are seeing a similar evaluation pathway come to the fore, but there are key differences. And if you just hit next again, we know that actually the pathway for AI as a medical device is far more variable than drugs and some other medical devices as well. And actually the AI medical devices can come onto the market at any point in this evaluation pathway. And so it's not the case that, oh, we have to have a randomized control trial for these kind of medical devices, software or AI as a whole. Actually, we can have these come onto the market and deploy them after any stage, any phase of validation type. And so what this means is that the burden of some of the evidence generation in terms of safety especially is shifted into the post-market surveillance phase. And that's where kind of the medical algorithmic audit can come in and plug some of those gaps. Could you go next, Jeff? Sorry, I can see a hand up.
Sorry, I didn't hear if we're doing questions at the end or as we go.
Should we do them at the end, Jeremy?
Oh, sorry, sorry.
Yeah, there's some in the chat as well. So if we let the guys, because sometimes they answer the questions, don't they? Because I've written down loads of questions, but they've already answered. So.
Great. So I will do kind of a very brief overview, so there's plenty of time for questions. We're kind of exploring this need for collaborative AI safety monitoring. We know that AI systems all have an error rate and will certainly fail in some way or another. And we're just beginning to understand what actually constitutes AI errors and harms. And we've seen guidance from the MHRA around adverse event reporting for software as a medical device. And we're starting to understand kind of how this works for AI as well. But we don't believe that any one part of the system can adequately detect and mitigate for these errors. And so we're working to use the medical algorithmic audit to understand how we can use a collaborative approach for kind of the error detection, analysis, and reporting. If you should go next, Jeff. Now, just a very, very quick overview of the medical algorithmic audit. As I mentioned, this has been published. It's a publicly available framework, and it's a 6-stage process where we start with scoping of the device itself and how it's being used, but also what the scope of the audit will be. We're also looking at then kind of mapping the AI pathway all the way through to testing the algorithm and reflecting on the findings, but in the context of the local deployment. And I'll cover these briefly in the next few slides. If you go next, Jeff. So the first stage in terms of the scope, as I mentioned, I'm going to cover these very briefly, but I'm happy to come to any of these bits afterwards. So the first bit is just defining the scope of the algorithmic audit. As Jeff mentioned, we need to understand the frequency of the audit. We need to understand what kind of data sets we're involving. And we need to understand which kind of clinical pathways are in question here. And then we kind of go immediately to looking at the intended use specification and specifically the technical files. So we're working across 3 different use cases at the moment, one for triage of skin cancer, another for autonomous reporting of chest x-rays, and we're looking at additionally AI for breast screening, and those are all in different levels of maturity, with the dermatology use case kind of actually deployed for routine use. We then kind of focus on discussion with stakeholders to actually identify the intended impact of the AI model. That's not something that the developer per se has already written up. That's very much a collaborative agreement between the hospital and the developer. And so kind of that's the final stage of the scoping part of the audit. And if you just hit next, Jeff. Then and just hit next again, so the slide's populated. Should be a diagram on the right as well. Perfect. So the next part is the mapping phase, and this is probably one of the most important phases of the algorithmic audit. The first is really understanding what the requirements for completion of the audit, which are often kind of slightly over and above that of a kind of normal routine clinical audit. But then we also, more importantly, want to understand what the healthcare task is, what the workflow is, what the different elements are, so that it allows us to undertake a failure modes and effects analysis and understand the key risks associated with not just the algorithm, but the AI system and pathway as a whole. And we kind of are doing this, and the approach we're taking is that we're kind of discussing all of the requirements with various different stakeholders in the ecosystem, including the AI developers. So we've had good engagement so far from the various different manufacturers, and so we're very much kind of working to explore how this should look with the engagement from the various different stakeholders that I've got listed on the right there. And if you just hit next, Jeff. One of the key parts of the mapping process, and I'm sure kind of all of you will have seen these kind of workflow flow charts. The first thing that we do is really understand what the pathway looks like and how this compares to the baseline non-AI pathway. And that then allows us to start mapping out, okay, what are the additional risks over and above the existing pathway. And if you just hit next. And then we, please don't try and read the next slide, but essentially it's just to show the kind of failure modes and effects analysis that we undertook. And this was very much based on documentation, so clinical safety documentation provided by the manufacturer, but also kind of the DCB standard, etc. And so we worked with that, put together this draft, and then worked with the AI manufacturer to actually kind of find the most important risks, which we assign risk priority numbers based on their severity, probability, and the likelihood of them being detected if the errors were to arise. And then that allows us to kind of start thinking about mitigation strategies, but also design our test phase and prioritize. If you just go next, Jeff. One of the additional kind of important points is the artifact collection stage, which comes after the mapping stage. And this is a table that we've put together around, it's kind of a checklist from the original algorithmic audit in terms of what we need to have access to But then we've tried to map out all of the different sources and where this information should come from. And so this is very much something that, yes, the manufacturer should have, but a lot of these won't actually be able to be created without a collaborative effort between the NHS Trust and the manufacturer as well. And I can come back to this slide and discuss it later. If you just populate the right as well, Jeff, there should be 3 boxes. So the test phase is kind of split into three parts. So yes, we would want to think about the overall performance of the AI medical device and how kind of what the accuracy is, what the metrics are. If it's diagnostic, we need to think sensitivity, specificity, etc. But where the kind of one of the most important parts of this test phase is the exploratory error analysis, and that's really examining each and every error that we've identified as important based on our risk priority numbers in the mapping phase, to then go through these errors and try and understand why the algorithm failed and whether there are any kind of patterns in those failures that might suggest a larger failure mode that we can address in consultation with the manufacturer and the additional stakeholders involved. We're also looking at subgroup testing. So for the dermatology use case, we've had a look at a range of different patient-specific subgroups. So things like age, sex, ethnicity, and Fitzpatrick skin type, etc. But there's an important point to note here that yes, we can predefine subgroups that we're interested in, but there will be subgroups that we might not necessarily know about. And then the last bit, which is not something we've explored in detail as yet, but I'm hoping to start thinking about this soon, is the concept of adversarial testing. So if we've identified potential failures that we don't necessarily have kind of a, let's say, a large enough sample size to truly interrogate, we can also start thinking about undertaking kind of a formal what if analysis, and that aims to try and break the algorithm and then start working backwards to try and stop that from happening in the real world. If we just go next, yeah. And then the last couple of slides just to finish up are kind of, okay, we've mapped out the pathway, we've mapped out all the various risks, and we've actually tested the algorithm, so we have kind of our findings. But then what do we do with all that? So that's the reflection stage, and it's very much thinking about what kind of risk mitigations we need to design, but then also assigning the tasks across the kind of developer clinical team divide. And I just wanted to add that yes, this is something that's being undertaken at a local level, but we are working with a range of different national bodies, including the MHRA, NICE, CQC, etc., to understand how we can actually feed some of this knowledge back up and try and kind of encourage a culture of shared learning to then try and inform future deployments or ongoing deployments in other parts of the NHS. And so this is definitely something that we're very interested in, and we're kind of having conversations about. And then if you just go next, Jeff, that should be my last slide. So this is just a very quick summary of the medical algorithmic audit framework that we're kind of applying and very much exploring at the moment. And I also just applied to kind of make a note that we are hoping to do some qualitative work to kind of layer on top of these experiences to actually understand how the medical algorithmic audit could be used in the future and how we can make it kind of feasible for a range of different NHS trusts to actually pick up and start using as a monitoring approach for AI safety as a whole. Jeff, thank you very much for helping with the slides.